Morning everyone. Morning. This is the start. Welcome to today's class. We'll be discussing dementia and the focus of the class is on classification and pathophysiology. Thank you to my supervisors, Dr. Sylvia and Dr. Mativo, and Dr. Sophia as well, who is with the participants. So maybe we could start with what one of you could let us know what you think, what you understand by dementia. Maybe one of you first starts. What's your own understanding?
You have You have cognitive abilities that are progressive, that go progressively worsening as opposed to the acute state for delivery.
Yeah, so that's correct. So dementia is characterized by a decline in cognitive function, and usually for it to be significant, it needs to show a decline from a previous baseline, and it needs to it needs to interfere with your daily function and independence. So if you look at the DSM criteria for dementia, you have the first thing is memory impairment. So either inability to learn new information or to recall old information, and then you must have one of aphasia, apraxia, or disturbance in executive function, and then like we said, it must result in functional impairment and is not due to an acute delirium or acute confusional state, and should not result from other medical or psychiatric conditions. So if we were to look at a broad classification of dementia, we have classification according to these different modalities: this etiology, the anatomic site involved, brain structures involved, either cortical or subcortical, and then we have early versus late onset dementia.
Just go back to the slide. Inability to carry out motor activities. It's actually inability to carry out motor activities despite intact motor and sensory function, as well as normal in the presence of normal comprehension. So it's not just motor, it's motor sensory.
So if we go back to this, then the first thing we'll look at is classification based on etiology. So dementia is very wide. It can be caused by multiple different things. The most common cause is usually Alzheimer's. This is both in Africa and globally. So Alzheimer's is the most common, followed by cerebrovascular diseases, and we'll look at each of these as we go on with the slide. Under cerebrovascular diseases, then we have multi-infarct dementia, and then we have diffuse white matter disease, sometimes called Binswanger's disease, and then we also have neurodegenerative conditions, infections, especially prion disease, PML, HIV-associated neurocognitive decline. We have things like normal pressure hydrocephalus, nutritional deficiencies like 1-K-Korsakoff, which we get in chronic alcoholics, B12 deficiency, folate, and then other metabolic causes like hepatic, thyroid disease. And then you have as well inflammatory conditions such as vasculitis, trauma, patients who get recurrent head concussions, who can get punch-drunk syndrome, and then tumors, especially the subfrontal meningiomas. So some cases are treatable, but this will be the minority of the cases. And then if we were to look at dementia based on cortical versus subcortical, so for the cortical, it will commonly involve the temporal, frontal, and parietal areas of the cortex. The subcortical will involve the subcortical areas of the brain, such as the thalamus, the striatum, and the midbrain. So this chart, this table is to help us just have a basic overview of the differences between cortical and subcortical dementia. So in terms of the typical example for cortical would be Alzheimer's versus PSP, which is for subcortical. Other examples of cortical dementias include Lewy body dementia, vascular dementia, and frontotemporal, versus other examples for the subcortical, which also include Huntington's and prion disease. So the main
Lewy body is cortical.
Sorry?
Lewy body disease is subcortical.
Okay. Noted, thank you. So other differences that can come in are things like the basic functional deficit. So in cortical dementia, you find specific deficits, things like apraxia, which we've just discussed, agnosia, aphasia, and then the main thing in the subcortical is about impaired information processing and executive function. This can also be seen in cortical dementia. It's not to say that it's not there, but those are the main that you'll find in each. And then other things you find that are different are in terms of the memory impairment, where you find that the patients with cortical dementia have poor recognition and have learning deficits, but those with subcortical dementia may be aided by clues and will be able to recall. And then other major differences are things like in the motor symptoms, where patients with subcortical dementia will have a lot of extrapyramidal symptoms, dystonia, rigidity, which is less common with the cortical dementia. And then, then other things like speech may be more likely to be abnormal in the subcortical dementias. So we'll start with our most common type of dementia, which is Alzheimer's disease.
But subcortical these days, Alzheimer's might actually having a cognitive ability. That's where the knowledge is coming from. Subcortical area, Alzheimer's might have some more cognitive ability. And that is what thinking now we are towards the Alzheimer's having some cognitive function. That's why you have subcortical lesions or degeneration, have some impairment in memory, some dementia symptoms. But then the question of overlap, when you look at your classification, you can have overlap, especially vascular dementia and other dementias. Patients will get strokes but still have Alzheimer's. Patients will get stroke, they still have Parkinson's disease like that. Therefore, there is overlap. Then, in another way you can classify as neurodegenerative dementias and reversible or rapidly progressive dementia, or you can classify as reversible or non-reversible dementias. A slide on rapidly progressive dementias is very important because this rapidly, usually Alzheimer's, by the time a patient will start coming, around 3 years since the onset or so. But rapidly progressive, within months, that patient is off. Therefore, that patient needs to be investigated fully, especially rapidly progressive. But neurodegenerative, that's not an emergency. A rapidly progressive, we look at reversible process and see if we are able to reverse.
I did have a slide up ahead about rapidly progressive dementias, but we could discuss it now. So other possible causes of that include things like autoimmune, paraneoplastic, infectious causes, vasculitis, can also result in a rapidly progressive dementia. So if we start on Alzheimer's disease, so like we said, it's the most common type of dementia. The biggest risk factors for Alzheimer's are actually age and a positive family history. We'll go into, in a few slides, we'll go into the genetic considerations that come up with Alzheimer's disease. Female sex actually also is a risk factor. Recurrent head trauma with concussion. I don't know how many watched the movie recommended by Dr. Sophie, called Concussion, appropriately. Then we also have environmental risk factors, things like exposure to heavy metals, mercury, lead, aluminium. Vascular diseases predisposed to vascular dementia. And then we have diabetes mellitus, and then others that are still under investigation include things like hypertension, low folate, elevated homocysteine, and leading of a sedentary lifestyle. So we look at...
The other thing is, this slide should not have put the one Alzheimer's disease, should have put that most common type, a risk factor. Because now that means diabetes is a risk factor. Therefore, I think that just needs a deletion.
You mean that these are risk factors for all types of dementia?
Yes, they are looking at them, they are of different types of dementia. That's that list. But when you put the topic Alzheimer, it means specific maybe for Alzheimer. We just will change there. Just this one class for dementia. Just general word. But the good slide, just what it is meaning to them straight. I get diabetic and Alzheimer. I get.
I'll change it before I start. So then, if we were to look at the genetic considerations.
Sorry.
Yeah.
Then you come across the protective factors for dementia. You come across things like people who are well educated, or people who, depending on their lifestyle, very active lifestyles in their childhood and then that's more likely to be protective of dementia.
I don't think it's protection, it's a progression. How fast progresses? When you are more educated, the progression is slower than when you are illiterate. There is not really protection here. Because what she's going to talk about in the next few slides, you can't stop it. It's a progressive degeneration condition. But it's slower if you are more educated.
For instance, they've looked at subjects. If you both get dementia and one starts off at a higher level of socioeconomic engagement, you're a bright person like a professor in university, you realize that by the time they get now the visible signs of the disease, it will be picked up much later than a poor farmer, for instance, in Ghana who's never been to school. So I find it's, as Machimo is saying, it's more for the progression of the disease. So it says that it can retard very rapid progression. That's why one of the ways you try to retard it is engage the person in mental tasks, both games, exercises.
What we call social stimulation, and I think it does not under you.
So in terms of the genetic considerations, so these are the 4 main genes that you need to know when it comes to Alzheimer's disease. The first 3 are more associated with early onset, and the ApoE4 is for late onset or sporadic cases of AD. So if we look at the first gene, so the APP gene, so it's usually found on chromosome 21, and it was noted because of patients with Down syndrome who would get to the age of 40 would be found to have this progressive neurologic decline. And so you find that, as I said, adults with Down syndrome develop the neuropathology of AD. So it results in excessive cerebral amyloid production, which is what then predisposes to Alzheimer's disease. Then the other 2 genes, presenilin 1 and presenilin 2, also predispose to elevated levels of amyloid within the body, and are more associated with the early onset of Alzheimer's. Presenilin 1 is the most common cause of early onset familial AD. Then you have apolipoprotein E4, which is found on chromosome 19, more common in late onset or sporadic Alzheimer's disease. It works by causing less clearance of the amyloid and predisposes to formation of neurofibrillar tangles, which we'll discuss. So what's interesting is, so in as much as this gene predisposes to Alzheimer's disease, there are many patients who have this gene but don't get Alzheimer's disease, and so it's not really predictive that if you have the gene you must get Alzheimer's disease, but it is more common in those who have Alzheimer's.
So you don't need to test for it. You don't need to test about before.
So now we look at the pathophysiology of Alzheimer's disease. So there are different theories. The main 2 are about the tau protein and the amyloid protein. And then there's also the cholinergic hypothesis, the oxidative stress hypothesis, and the metal ion hypothesis. So if we start with the cholinergic hypothesis, then you find that there's usually a decrease in the cortical levels of neurotransmitters within the brain, especially acetylcholine. And this could be from a deficiency in the synthetic enzyme, which is called choline acetyltransferase. And you may find there's also a reduction in the number of cholinergic receptors within the brain. So this a way of telling that this contributes to the pathogenesis, the fact that giving these patients acetylcholinesterase inhibitors can, such as donazepam, can help with the reduction of the progression of the symptoms. Other theories, so we have the tau protein synthesis. So tau protein is a microtubule-associated protein. Its normal role is to aid in microtubule assembly and stabilization. In Alzheimer's disease, you find that the tau proteins become hyperphosphorylated and they aggregate to form a helical filament, which then is a major component of the neurofibrillary tangle. And then you find accumulation of this phosphorylated tau proteins is neurotoxic. Then you have the metal-ion hypothesis. So metals such as aluminium, lead, and mercury have been hypothesized to also contribute to Alzheimer's disease. So you find that there's neuronal loss. All of these eventually contribute to neuronal loss and then atrophy, especially in the temporal and the frontal cortex, with resultant inflammation, deposition of the amyloid plaques, and the neurofibrillary tangles, which subsequently leads to Alzheimer's disease. So now we'll look at the amyloid theory. So in Alzheimer's disease, so you have the amyloid precursor protein that's broken down by both the beta secretase and the gamma secretase into beta amyloid. So when you get a lot of the beta amyloid, you have formation of the fibrils, which can result in oxidative stress and inflammation, and then you get altered kinases and phosphatases forming neurofibrillary tangles. On the other side, you have fibril amyloid causing neuronal and synaptic loss by formation of senile plaques in combination with the activated microglia. Yeah, is that clear? Should I go through it again? It's a very important.
One more time.
One more time. Okay. So you start here with the amyloid precursor protein being broken down by the beta secretases and the gamma secretases into beta amyloid. The genes we talked about, the presenilins 1 and 2, the apolipoprotein E, contribute to this breakdown of the apolipoprotein by the secretases, and then you have formation of the fibrils. Okay, so when you have it goes down two pathways. So if you go down this way, so when you have this fibril interacting with the activated microglia, then you have formation of senile plaques, neurofibrillary tangles. Then the fibrils by themselves can also cause increased oxidative stress, inflammation with altered kinases, and then you also subsequently get the neurofibrillary tangles. So when you have these, then this deposition of these neurofibrillary tangles within the neurons causes neuronal loss, and then ultimately you get cortical atrophy and features of Alzheimer's disease. Is that clearer?
Yeah.
So we can look at the clinical manifestations of Alzheimer's disease. So the main thing, so we could look at it as progressing from mild cognitive impairment, then mild, middle, and late disease. So the first signs that you get are difficulties with memory. So then in the early stages, it may not really be recognized by anyone. And here, this is what is called the mild cognitive impairment, where you have the memory loss falling below 1.5 standard deviations before normal. So mild cognitive impairment can be considered as early or asymptomatic AD because it's very difficult to pick up. And you find that patients who have mild cognitive impairment progress to Alzheimer's disease. About half of them who have mild cognitive impairment will progress to Alzheimer's disease over a period of 4 years. So the initial memory impairment is you find the patients are able to remember long-term memory, but they have difficulties with recent memory and recall. So in the early stages, you may find as well that they are the biomarkers of Alzheimer's disease, in that if you were to screen them, maybe with a PET scan, you may find positive amyloid imaging, but the patient is asymptomatic. So then so with time, you find that the cognitive impairment affects activities of daily living, things like keeping track of finances, following instructions at work, driving, shopping, and then some patients may have nausea, which is where they're unaware of the deficit. And then in the middle stages, we find that small changes in the environment destabilize the patient. So things like hospitalization could tip these patients into delirium. And then in the middle stages, so these patients are now unable to work without supervision. They need someone to take care of them every day. And then they get language deficits. So things, they are unable to name objects, and then difficulties with comprehension, difficulties with fluency, and then apraxia, like we mentioned. And then you also get visual spatial deficits, where they're unable to dress, eat, walk. They can't solve simple puzzles. And then towards the late stages, you find that they're wandering aimlessly, they get lost, they have loss of judgment and reasoning, Capgras syndrome. Does anyone remember what Capgras syndrome was from psychiatry? So Capgras syndrome is where you believe that you've been replaced by an imposter, or the caregiver has been replaced by an imposter. Yeah. So towards the end, you may find that there's some overlap with Parkinson's disease, and then in the very end stages, they are bedridden and they die of things, complications of being bedridden, aspiration, pulmonary embolism, infection, malnutrition. So the typical duration is 8 to 10 years from beginning to end, but this is very variable among patients and can go up to 25 years.
Alzheimer's starts from parietal lobe. That's why visuospatial comes first. Goes to temporal lobe, you get sensory issues. Then goes to frontal lobe, then you get attention, behavior, and executive function impairment. The first area is actually parietal, temporal, then frontal. That's how the stages there are.
You can see that I'm trying. What is agnosia? What's agnosia? Which they look hard, but not to, when you understand what they are and you look at the patient, you understand something. Like agnosia is an ability to recognize stimuli that the patient could previously recognize. Like there's once I had a patient who couldn't recognize the husband by his voice, and then the son grew a mustache and she could not recognize him because of the new mustache. So they're unable to recognize stimuli that they could recognize before. And then there's prosopagnosia, where they can't recognize faces. And then the apraxias also, as Mateo said, it starts with the parietal lobe. So the different types of apraxias will tell you which parietal lobe. Like the dressing, you find somebody has worn 2 shirts or has worn the trousers on top of the head, they can't button, they can't do things. Or you ask them, how do you test? You ask them, like, say people show me how you comb your hair. They can't recognize how they comb their hair. Show me how you use your toothbrush. So instead of brush your teeth, so instead of using the toothbrush, you find they use their fingers, such things. So when they can't be able to understand the use of simple tools, like a carpenter, you find he's been a carpenter all his life. He can't use, for instance, the plane or the chisel. That's more of now ideomotor, which now point to the dominant parietal lobe. And then things like dressing and construction. That diagram we draw the mental, when you tell them to draw, they can't be able to make sense of it. That's construction. That one is more of the non-dominant parietal lobe. So the different apraxias will tell you, and yet they have normal motor function, they are not weak, sensation is intact. They can comprehend what you tell them, but they just can't carry out a set of tasks. So those are very important features. So the agnosias, the apraxias, and even the phases. So those are, as Mateo said, will tell you which part of the lobe. So you can see initially the agnosia, the apraxias, those are the parietal lobe, and then you come to the temporal lobe, where they have now issues with memory, mild cognitive impairment, and then it becomes much more pronounced. And the very fast memory losses, they lose their recent memory. So recent memory is the first to go in Alzheimer's, and then they go to the front. They can't plan, they can't carry out any function, they can't make decisions. So before, we will be told my dad used to be a very good businessman, we have a business, who used to keep a log of everything, and especially women, very OCD-like, they know where they keep their house keys, they lock up all the doors at night. So the husband tells you, nowadays she leaves all the lights on in the house, I find the doors unlocked. So before, they used to depend a lot on the mother. Families will tell you, we used to depend on my mom. She was perfect, she could do everything. Now we have to go around after she's gone to bed, check all the doors, put off all the lights because something is going on with her. We can't understand. So by the time all this come on, the Alzheimer's has started way before. How many years? What, 2 to 3? By the time the symptoms come on, it has already started about 3 to 4 years before.
She's going to show.
It's just like Parkinson's. So the symptoms appear 2 to 3, 4 years after the onset of the disease.
Okay. So this is the chart Dr. Matib is referring to. So it just simplifies what we said in an easier way to remember. So for the mild, so here you have just difficulties with some minor memory loss. And what Dr. Silva is saying, the long-term memory is intact, but then the recent memory and recall is impaired. And patients you may not really be able to notice that there's any change with the patient. Then when you move on to moderate is where you now have the difficulties with judgment, daily tasks, communicating. They may get behavioral changes, especially they may get frustrated with the deficits that they're having. And then by this stage you find that they need a caregiver to assist them with their day-to-day lives. And then when you move on to the severe stages is where now patients are bedridden, they're completely incapacitated, they're completely dependent on those around them. They may get difficulties with bladder and bowel control, and they're more likely to not be violent and aggressive. So it's just a summary of the previous slide. So we'll move on to vascular dementia. So for vascular dementia is dementia associated with cerebrovascular disease or cerebrovascular risk factors. It may be found with other types of dementia, Alzheimer's and the rest, and there are two main types. So you find you have multi-impact dementia as one type, and the other type is diffuse white matter disease. So the difference between the two is when you have multi-impact dementia, the patients are more likely to have focal neurologic deficits. These are patients who've been getting recurrent strokes, whether small or large, and the occurrence of dementia may develop depending on the total amount of brain affected. Meaning the more strokes you've had, the more likely you are to have vascular dementia. So they have stepwise disease progression, which is where with stroke they have a further decline from their baseline, and then another stroke and they get even worse, another stroke they get even worse. And you may find patients with cerebral amyloid angiopathy, which you can get in Alzheimer's disease, are predisposed to brain microhemorrhages, which again gives them the small strokes, and then they get the multi-impact dementia. So that's why you find there's that overlap between the two. Then the other type is the diffuse white matter disease. So this is more of an insidious onset and slow progression. You don't get that stepwise decline, and this is mainly associated with microangiopathy, or you have vaso-occlusion of the small penetrating arteriole. So the focal deficits that you may see with the multi-impact dementia are the same ones you would see in a patient with stroke: unilateral hemiparesis, pyramidal signs, cerebellar signs. You may find gait abnormalities, pseudovalvular signs. And then for the symptoms that they get are similar to those of Alzheimer's: difficulties with memory, apathy, difficulties with executive function, judgment, and orientation. So this is a slide that's comparing vascular dementia versus Alzheimer's disease. So in vascular dementia, the history of cardiovascular disease is higher or is stronger. So you find you had TIA, strokes, or they have risk factors, things like diabetes, hypertension. So it can also happen in Alzheimer's disease, but is more prominent in vascular dementia. The onset in vascular dementia may be sudden, as in happening just after a stroke, versus Alzheimer's, which is generally gradual. Progression is usually slow and progressive in Alzheimer's disease versus stepwise in multi-impact dementia, and can also be slow in the diffuse white matter disease. The patients are more likely to have neurologic deficits if they have vascular dementia, and the gait abnormalities are disturbed earlier in vascular dementia as well. So those are the main differences. And then on neuroimaging, you'll find patients with vascular dementia have either signs of previous impact or they have the diffuse white matter disease, versus on Alzheimer's disease where you find atrophy as the predominant neuroimaging finding. If you have any questions or clarifications, feel free to stop me along. So then we'll move on to frontotemporal dementia. So frontotemporal dementia begins in the 50s to the 70s. Family history may be present, and in those with family history, the inheritance is usually autosomal dominant. There are three core clinical syndromes. There's the behavioral variant, semantic, and non-fluent variant. So the behavioral variant is actually the most common. It may be accompanied by deficits in executive function. The main symptoms are emotional and social difficulties. So they are apathetic, they're disinhibited, they're compulsive, loss of empathy, and you'd expect this because of involvement of the temporal lobe. Then the other two variants, the semantic and the non-fluent, fall under primary progressive aphasia. So for the semantic, we find that they have difficulties with comprehension. So they lose the ability to decode meanings of words, objects, or emotion, versus the non-fluent variant, which is where they have prominent motor speech impairment. They are unable to produce words. So it's almost similar to Wernicke's and Broca's aphasia, if you think about it. So frontotemporal dementia may also be accompanied by motor neuron disease. You may find an overlap between the two. And corticobasal syndrome and PSP, which we're going to discuss, are also part of the frontotemporal dementia spectrum. So those are the genes involved in frontotemporal dementia. And when it comes to pathology, you find that there is frontal, insular, and temporal atrophy. And those are the things we look for on imaging of such a patient. And the cortical serotonergic system is involved and impaired, but unlike Alzheimer's disease, there is sparing of the cholinergic system. So if you were to give these patients acetylcholinesterase inhibitors, it's not likely to work. Yeah. So this.
Remember the patient?
Yes, we have a patient. She just went home 2 days ago who had features of frontotemporal dementia. If you could, I could send the AK number on the group. She had the classical loss of the frontal and the temporal focal atrophy, and her symptoms were also very much in keeping with frontotemporal dementia, possibly the behavioral variant.
And you treated that with SSRI?
Yeah, which is another SSRI.
Not anticholinergic.
Okay.
And for this patient, that's why you choose, so when they come with psychotic episodes, that's why you choose the kind of antipsychotics you use. Like for the Parkinson's, you want to give less of the anticholinergics, whereas for the other ones, you want to give more cholinergics. And then for the temporal, the SSRIs, because you can see they have most of the serotonergic. So it's not just to just give any, because if you give the wrong one, you can lose.
So this slide, I think you probably look at it in your own time, which is a summary of what we discussed. I don't know if it's very clear. It talks about just the different findings in each of the variants of frontotemporal dementia. So when we move on to PSP, which also falls under the frontotemporal dementias, so for progressive supranuclear palsy, the things to, so those are the areas of the brain that are involved, the brainstem, basal ganglia, limbic structures. Then the symptoms or things to look out for. So these patients typically have a lot of falls, and these falls are as a result of inability to look down because of the oculomotor syndrome that they have. So they have progressive oculomotor syndrome. So they have features of an oculomotor nerve palsy. They have square wave jerks, slow saccades, and then what you notice is that the oculocephalic reflex is preserved, and that's what makes it a supranuclear palsy. Does anyone remember how to check for the oculocephalic reflex? The doll's eye reflex. So these patients, and it's progressive in nature. So you find that they fall because they're unable to look down, and then they have axial rigidity and poor judgment. And you may find that they also have behavioral symptoms, so it frequently overlaps with the behavioral variant of frontotemporal dementia.
How do you differentiate falls of Parkinson and falls of PSP? Both fall, and how they fall. PSP fall, Parkinson fall. From these PSP patients look they don't sit down, therefore they fall back. Parkinson, flexion posture, they fall forward. We need to ask, do they fall backwards or forwards? Okay, let's go.
Thank you.
These people fall like this. They don't see it here. So they usually going to fall backwards. Okay, there is a drum, there is a tape. Check when you have to check for the progress.
To add up to what Dr. Martin was saying, they have what is called, like that's what you say, they have a praxis. You know, praxis in ability. So they have a praxis of eyelid opening, so they can't open. So maybe it's the elevator which is involved. So that's why, you remember when Dr. Buka had mentioned, they have hyperactivity of the frontalis muscle. So it's like they are frowning. The reason is because they are trying to activate this muscle to keep their eyelids open, because they have a praxis of eyelid open, that levator inhibition. So they are always looking up, so they can't sit down so as much as they fall back. So all these things are related. You go sit down, and then you have to see patients. When you see patients, you don't forget. And then this is part of the movement disorders, the atypical Parkinson's group of disorders. So the tremors are there, they'll have the rigidity, they have the bradykinesia. But for them, it's a bit more typical for Parkinson's because it tends to be bilateral very early on, as opposed to the Parkinson's. So all those features are together, the supranuclear palsy, the rigidity, they are very stiff, bradykinesia, they have tremor, more symmetrical than asymmetrical.
The other key to differentiate clinically Parkinson disease is Parkinson class syndrome or typical Parkinson is this tremors. Tremors in Parkinson disease will be made unilateral, more in one side than the other. But the Parkinson plus syndromes, they are symmetrical. Therefore, those are questions when you have a patient you ask, tremors started both sides or one side? Because when they start both sides, the patient has Parkinson's features, but that is not true Parkinson's disease. But if it's unilateral, so you started here and then later this, that's classical Parkinson's patients.
Come to the clinics where you see them. We don't admit many of this.
I think it will be easier to tie in once you have seen a patient. I should have seen the symptoms.
This one of Dr. Martin who keeps on coming very frequently. He's still alive, then he said. Yeah, so make a habit of calling each other when you see an interesting patient. Tell the rest to come and see.
You have jumped us.
Oh, sorry. So then there's the corticobasal syndrome, also falls under can overlap with the frontotemporal dementia. So it's a combination of a progressive dementia and a movement disorder, which usually involves the basal ganglia and the perineurothalamic cortex. So these patients have asymmetric rigidity, dystonia, and myoclonus. Something interesting that they undergo is called alien limb phenomenon, where their limbs can have unintended motor actions, grasping, drifting, or undoing. and it eventually becomes bilateral with prominent involvement of the frontal and temporal regions, and then they get dysarthria, intention tremor, and slow gait. So there's Lewy body dementia, which can sometimes be called the Parkinson's disease dementia. So these patients have visual hallucinations, they have symptoms of Parkinsonism, they have REM sleep behavior disorders, and the dementia can come before or after the features of Parkinsonism. So if the symptoms of dementia happen after the diagnosis of Parkinson's, then it's called Parkinson's disease dementia. If the symptoms happen at the same time, the symptoms of dementia happen at the same time or before the symptoms of Parkinson's, then we call it Lewy body dementia. So
Let me just correct you before you absorb this. If you change that disc, Lewy body disease and Parkinson's disease dementia are two very different things. So there is Lewy body disease and then there's Parkinson's disease dementia, where the patient get dementia when they have Parkinson's disease. So the difference is that Lewy body disease, the dementia starts before the features of Parkinsonism or at the onset together. Parkinson's disease, the dementia and the cognitive decline begins way after the Parkinson's disease has been diagnosed, maybe 5 to 6, 7 years later. So those are two very different concepts. And Lewy body disease is one of them, atypical, as Matthew was saying, the Parkinson class syndrome, one of them. So these are two very different things. There's Lewy body disease, which presents with dementia very early on, and there's Parkinson's disease, where the dementia comes years into the onset of Parkinson.
And the characteristics of Lewy body disease. A patient comes with, let's say, psychotic features, so they usually go to the psychiatrist, or comes with Parkinson's features. You give them Parkinson's developer, it worsens the behavior psychosis. You give them psychotic drugs, it worsens Parkinson's. So it's a very hard patient to manage. This is not an easy patient.
And many of the family will not even remember when the Parkinson started. So sometimes you find the history, they are not very good historians, and many of the patients will recognize the symptoms before even the family picks it up. And you find maybe they live alone, they live with their spouse, they become forgetful, and the family doesn't realize, they only realize when the disease is advanced. So as Dr. Martin was saying, it's very hard to, but their visual hallucinations, behavioral disorders are very upfront. It's more likely to be Lewy body as opposed to
so the first manifestation of the disease could be delirium. So Lewy bodies are, when you look at the neuropathology, you find this deposition of Lewy bodies in the brainstem, the substantia nigra, the amygdala, and the cingulate. So Lewy bodies are intraneuronal cytoplasmic inclusions that stain with periodic acid shift. And these Lewy bodies usually have epitopes on them that are recognized by antibodies against the alpha-synuclein. So that's why it's called an alpha-synucleinopathy. So they may have profound cholinergic deficit, which is responsible for their fluctuations in attention and visual hallucinations. So this is almost a summary slide, just listing the tauopathies versus synucleinopathies. And so the main the main protein that's deposited. So for the alpha-synuclein diseases, you have things like Parkinson's, Lewy body dementia, Parkinson's disease dementia, multi-system atrophy. For the tauopathies, you have Alzheimer's. It's not listed here, but Alzheimer's is also a tauopathy. You have progressive supranuclear palsy, cortical degeneration, Pick's disease. Some of these I don't think you need to know. And then for beta amyloid, you have Alzheimer's disease and cerebral amyloid angiopathy. It's probably good to look at this before MCQ. So then you have other causes of dementia, which we'll just mention, things like prior diseases that cause rapidly progressive dementia. We already talked about this. You have Huntington's disease, normal pressure hydrocephalus, Patch-Drug syndrome, and Wernicke-Korsakoff syndrome. So for normal pressure hydrocephalus, it may coexist with other dementias. And then there's the clinical triad of normal pressure hydrocephalus. Does anyone remember? Yeah. Yeah. Ataxia, dementia, and urinary incontinence. So they get a glued gait or a magnetic gait. So they have external hip rotation, low foot clearance, so they'll get their feet off the ground in very short strides with a prominent truncal sway or instability. When you look at the neuroimaging, you find enlarged ventricles with minimal cortical atrophy. So it's a communicating hydrocephalus. And these patients will commonly have a prior condition that could have resulted in meningeal scarring and reduced CSF reabsorption. So there's the pathophysiology of normal pressure hydrocephalus. Would you take us?
Okay, I can try. I read it once. So basically, the normal CSF production occurs in the choroid plexus of the lateral ventricles, goes down the aqueducts through the foramen Monro and Luschka into the basal cistern, and then into the into the subarachnoid spaces, and then it's absorbed via the arachnoid villi. So with normal pressure hydrocephalus, what happens is that if there is any insult, so you either have an idiopathic, which can be gene related, which can cause, if there's any insult to the arachnoid villi, and then of course there'll be decreased absorption causing the increased size in ventricles. So ideally they say normal pressure hydrocephalus, but it should be called transient normal pressure hydrocephalus because the first opening pressure may be high earlier on in the disease. Then there's this Hakim and Adams formula, which is forces equals to pressure times area. I can't really remember that part, so maybe you could carry on. But that's the basic pathophysiology of it.
If you put a CSF monitor, the pressure goes up at night. They go up at night, but if you put a monitor, CSF monitor.
So it's more or less what Father has said. You have reduced absorption of CSF at the arachnoid villi, which causes an increase in the CSF pressure. So initially you'll find there is a raised intracranial pressure that causes, so this force against the brain causes an increase in the size of the ventricles, and then with time now as the ventricles enlarge, then there's enough area, so you find that the pressure goes down to normal. So that's why they end up having normal pressure hydrocephalus later on. So in terms of the imaging, so this is normal, and then here you can see the ventricles are enlarged, and then there's minimal cortical atrophy. So this is what is classical for normal pressure hydrocephalus.
Now from that image, because the ventricle is ventricle stretches the fibers as they come from the cortical area going down. That is why you have the symptoms sort of the stretch. You get this gait, you get this urinary frequency, and because of this, the memory is also good. That is the stretch from the ventricle to the
So I'll just.
And that is why when you reduce the pressure, 60% of them will peak because the pressure comes down. And the stretch
which says that there's decreased absorption in the arachnoid villi. Is it like a constructive picture?
You see, these are presumed beings. Either there is decreased absorption or there is increased absorption. These are presumed mechanisms.
So it's different from obstructive, not communicating hydrocephalus.
It's thought to be more about communicating, less of an obstructive picture. That's why they are looked sometimes post-traumatic, some arachnoid, say the inability to fibrosis, they reduced absorption. But it's more the fact that the villi are producing in the circulation and it's less of the absorption, but it's not really an obstructive, your conventional obstructive area.
It's like mallards or
Yeah.
So we'll just look at some of the investigations that you would routinely order or consider ordering for a patient to present is under evaluation for dementia. So the main thing we'll be looking for in the lab investigations is potential reversible causes, anything that's treatable. So metabolic abnormalities, vitamin deficiency, thyroid abnormalities. So you do a B12, thyroid function, HIV, behavioral. CSF may or may not be done depending on the clinical scenario. Then you see some electives. So the features on imaging, so you may consider CT.
CSF is a must. CSF is
So when it comes to imaging, you may do a CT head or an MRI depending on the resources available. MRI is preferred. The features or the things that you look for are cortical atrophy. So you compare the amount of atrophy with the age of the patient, and you may look for things like hippocampal atrophy in Alzheimer's disease. And in Alzheimer's, you may also get posterior cortical atrophy or medial temporal artery. And then things like frontotemporal dementia, you get frontal and temporal atrophy. In normal pressure hydrocephalus, you do ventriculomegaly. You also look for features of ischemic cerebrovascular disease, which will things like partial focal infarcts or just the diffuse white matter changes, and then microhemorrhages, which can be seen in cerebral amyloid angiopathy, which you see in Alzheimer's disease. So in younger patients, those who have early onset dementia, you may consider genetic testing, especially if they have a strong family history. You may do advanced neuroimaging, PET scans, or SPECT to detect beta amyloid. In the CSF, you look for either elevated tau or low beta amyloid. You may look at ceruloplasmin and urinary copper to test for Wilson's disease.
in the CSF for rapidly progressive Brown disease.
Sorry?
Brown disease.
Yes, in the CSF. So what should we look for? So you may look for infectious or inflammatory.
Brown disease.
Or could spell chocolate. Brown disease. Or could spell chocolate. Or the GC virus. So,
Protein.
1433.
sorry?
Protein 1433. Is a GC virus for protein?
No, it's for PML.
So you should also look for it, especially in patients who are HIV. And then even in the background HIV, you also need to do CSF because there are so many other things. Viral pathology can also cause progression of dementia. And all that. Why are you looking at ceruloplasmin and urinary copper?
Wilson's disease.
So those are differentials of cognitive decline in younger patients.
Okay. So just wanted to look at some of the imaging. So in this patient, so this belongs to a patient with Alzheimer's disease, and you can see the medial temporal atrophy. And then in this, it's visible in the back. So here is predominantly posterior cortical atrophy, which you can also see in Alzheimer's disease. Then here you have microbleeds that you would find in vascular dementia.
Which one is plasma?
Sorry?
That's the second.
The second one.
You get posterior cortical.
That's what I thought. Maybe could let us know.
From your definition, you said for the temporal.
Correct.
Right.
This is occipital. This is a visual. I think this is like not really the white matter changes more than because occipital will not take you to be the molecular cognition and aspect from the hospital. But when you look at the MRI, they are also hyperintensities in the white matter.
Okay.
So
this was the diagram of, so imaging of frontotemporal dementia. So here you can see the frontal atrophy. And then, so this was a diagram showing Lewy body disease. So this is a radioisotope scan. So then this is the normal, this is abnormal. So you have a reduction in the dopamine. Yeah, so there's reduced dopamine uptake in the basal ganglia on the right, which you see more in Lewy body disease. And then for this last imaging, this is an FDG PET scan. So the good metabolism is usually red, and then blue is reduced. So this shows temporal and parietal hypometabolism that's seen in Alzheimer's disease. So I just had 2 cases to discuss. So Janet.
A 72-year-old right-handed male with a history of atrial fibrillation and chronic alcoholism is evaluated for dementia. His son gives a history of a stepwise decline in the patient's function over the last 5 years with the accumulation of mild focal neurological deficits. On examination, is found to have a pseudobulbar affect, mildly increased muscle tone and a brisk deep tendon reflex in the right upper extremity and an extensor plantar response on the left. The history and examination are more consistent in each of the following. With Swanger's, Alzheimer's, Jacob, vitamin B12, I think I would, given that it's been progressive, and then there's focal neurological deficits, the increased tone, deep tendon reflex, extensor plantar, and there's history of atrial fibrillation, chronic alcoholism. I would go with multi-infarcts.
Yeah, so it's multi-infarct dementia. Then the other thing is the stepwise decline. Why not? It's possible with the chronic alcoholism, but I don't think it will give you the focal. Sorry?
Combined degeneration of the cord. And we try and explain
What
describe the case for me. It's multi-infarct dementia, which means on my she draws
Then as a team, when you see atrial fibrillation, that's what you mean. Because it tells the patient what's been Swanger's disease?
It's
It's the other form of revascular dementia. So there are 2, is a multi-infarct, the
Subcortical.
It's more extensive white matter disease when it's leading to cancer.
Actually, it's a version of central surgery. Look at it in a different
So white matter disease is extensive.
Then we have a second case, Antonina.
Middle-aged male patient was noted to become restless in his sleep around age 60. At age 62, he began experiencing issues with inattention and problem solving. At age 63, he began showing a tremor in his hands, and he began stumbling and falling. He was diagnosed with Parkinson's disease. Since then, his cognitive problems worsened. No changes in memory noted by the family. He recently got into an automobile accident, driving the wrong way on a street. He also started experiencing hallucinations. He reported seeing small animals and children in his home, even though no animals or children were present. He would also begin losing track of time, and he would insist that he had appointments on days that he did not. His walking became worse, and he began falling more frequently. After a particularly nasty fall, he was taken to hospital He was evaluated at A&E and the casualty doctor asked at the end. Based on his history was the most likely diagnosis. So this patient started having frontal. So initially the inattention and problem solving, that's temporal, and then tremors. So he had features of, say, Parkinson's. So the Parkinson's came before the memory decline, which came now later, and then he has visual hallucinations.
So the cognitive issues came before the
cognitive came, no. Yes, cognitive came before the tremor.
Do you think
The
this
Parkinson's.
was Parkinson's?
No, not Parkinson's disease. Maybe Parkinson's plus or Lewy body.
Which one do you want?
Lewy body.
So what clues in the history can tell you it's Lewy body dementia?
Because the features of Parkinson's disease, not the Parkinson's. They came later and then we have visual hallucinations.
What else other than that?
So for the past 3 years, he was having like cognitive issues, inattention, problem solving. And after that is when he developed the tremors, the movement disorders. So is this what you said, what comes before the cognitive thing that comes before the tremors, think about the body more than Parkinson's.
And then he also has a sleep disorder as well. And then there's also falls, although falls are not really specific. Okay, so it was Lewy body dementia. Okay, so that's the end of our class. Thank you everyone. I know it was a bit of a heavy class with so many things. Yeah, but I'll send the slides. And if there are questions, we can always discuss after.
Ask the teacher question.
Yes.
She's a good teacher. Which metals are being treated?
Sorry?
The metals.
The metal. So gold, mercury, aluminium.
Lead.
And secondly, that's like for the staging of AD, mild, moderate to severe. So, Doc, you said the issues start in the parietal lobes. I have 2 questions. How is it that the mild one, where it starts from the first initial 2 to 3 years, that the patient has more like short-term memory loss as per this, and not actually doing activities like you said, putting on a shirt or a trouser, not the right way? How is it that it's just talking about short-term memory losses rather than apraxia actually?
What exactly are you asking?
So you said that
symptoms are
Alzheimer's
very
starts.
profound as you go along, or?
Yeah, like Alzheimer's starts in the parietal, so that
Yeah.
should start with apraxia. But this one, it's saying that it starts more with short-term memory loss rather than apraxia.
temporal.
It's because it starts very early. In fact, in the beginning, they're actually asymptomatic.
Yeah.
So the patient just begins by misplacing things here and there, because the pathology is not just limited to the parietal. It's the same process is going on in the parietal, the frontal, and the temporal lobe throughout because of the pathophysiology. So the oxidative reticle injury, the hypophosphorylated tau. So it's happening all over, but the parietal becomes more prominent because that's where now you have the activity, day-to-day activity. That's the first thing that happens.
Oh, that's what's recognized first.
Very early. Yeah. So the memory, it's actually the patient who picks it up first, that they are misplacing their keys, but the family really doesn't know. So it comes to attention when they start doing interesting things. But when you take the history, it starts very early on with very mild cognitive impairment. And cognitive impairment doesn't just refer to memory only. There are many domains. There's attention, there's perception, there's language and memory, and then there's also the executive functioning, there is a spatial. So there are different domains. But what becomes more apparent are the ones which are more profound in the activities of day-to-day living.
And if the parietal lobe is involved, how comes AD does not have sensory deficits?
See, parental is not only for sensation.
Okay, so it does not involve that. Even in advanced stages where you have generalized cortical atrophy, there's never a sensory deficit in AD. It's mostly motor cognition. That there is therapeutic reason as well.
See, parental lobe also deals with the word storage.
Yes.
Okay. It does not only just sensation. The sensation is not usually affected. But the other aspects of the parental lobe functions are important. And usually at this point, not many people will recognize. But unless you do neuropsychological assessment, you even, let's say, construction of visual, spatial deficits. They will not be talking about any memory, and people will not even notice.
Yeah.
But sensory is not involved in that.
There's no particular reason as to why it's not.
Yeah, we don't, that one, we don't know.
Even the motor is not so involved. You notice the motor is much
Later, very late, yeah, when you're global
it
age.
becomes
Yeah.
literally shut down.
Yeah.
So it's more cognitive. I think it's because of the neurotransmitters. They need to check on that.
Yeah, that too. Doc, you said the acetylcholine transferase levels are decreased.
Yeah.
Decreased. The one that synthesizes acetylcholine. And the acetylcholine esterase goes up.
No, so
That breaks down acetylcholine.
No, so you have reduced synthesis and then you have fewer receptors. So that you have reduced activity of acetylcholine.
And the acetylcholine esterase of the side.
You see, doctor,
Yeah.
you have genetics for gradation in the family. And we did actually sort of go to the issues which codes for you need to metabolize or use it as red. Okay? Therefore, we believe the gene which codes for the gradation of this, we don't know, that's why we don't have any protective drug. We believe the gene is the one now on to delete the nerves. Okay. Now, when you're deleting the nerves, this is a slow process. These nerves are acetylcholine producing fibers. Therefore, the fewer the number of neurons producing acetylcholine, you're going to have generally reduced acetylcholine production because the fibers are less. And the treatment is not, you can't reverse. What we need is to maintain the acetylcholine to be able to stimulate fewer fibers which are still there. Then in the process, you find you start with the acetylcholine inhibition. Then since the degradation of the nerves is going on loss of the acetylcholine, the fibers is going on, you find you need to increase the dose. Because the fewer the fibers are there, the more you want to have more acetylcholine available.
Yeah.
But definitely over time, you need a higher dose. Then at the end of the day, there is no effectiveness of the drug. And that is why she was saying about another. Okay. The other option is you can, because of the other part, you can go through NMDA inhibition. And that's why the nopazil you still have to increase the dose until there is no purpose to even increasing the dose. Because the neuronal loss is going on over time, slowly. You are only working on elevation of the neurotransmitters that I call in the availability. That's all what you are dealing with. And that's why you don't have anything to do. You can't reverse this condition. Therefore, you go back to the genetics, the deleting gene is on, the metabolic gene is on. Therefore, the addition continues, therefore, you get the normal dose.
Okay, I think we should end that for purposes of time. Thank you, everyone.
Thank you.